welcome to this episode of Spotlight on Policy. My name is Stephanie Witt, and I'm the director of the Public Policy Center at Boise State University. You're joining us for the first in our series on healthcare reform as our nation faces major decisions about how to reform our healthcare system. We are joined today by Dr. Jim Girvan, Dean of the College of Health Sciences and Professor of Community and Environmental Health at Boise State University, and Dr. Sarah Toevs, Director of the Center for the Study of Aging and Professor of Community and Environmental Health. Thanks for joining us, Jim, Sarah.
Thank you very much, Stephanie. It's nice to be here.
Thank you. Good to be here.
Today I'd like to talk about the big picture in healthcare and give our listeners the kind of information they need to understand the debates as they rage across the country. What is it like now? How do we do it now? What do some of these terms mean that we hear people talking about in the media? Jim, let's start with you. Could you give us some kind of understanding of what is our system like now?
Well, there's two statements that I kind of, when I talk about this, I like to start with. Mm-hmm. First of all, they're kind of true-false statements, all right? The U.S. has the best healthcare system in the world. The U.S. has the worst healthcare system in the world if we're looking at high market economies. And the fact of the matter is both of them are true. And so I think we end up with, let's say, proponents of the current system saying, gee, we've got the best healthcare system in the world. We have the best education. We have the best technology. We can get right in and have access and so on. That is true if we have, with the caveat, is if we have generally an insurance policy that allows that pays for that, and or we're very wealthy, so it doesn't matter whether we have an insurance policy or not. The U.S. has the worst healthcare system in the world in terms of market economies would also be the case because, at least in the sense of, do we get what we pay for? We spend far more than any comparative nation. And our health outcomes, I just was reading actually yesterday on the World Health Organization reports that we're 29th in health outcomes in the world, things like infant mortality and so on. So immunization rates and those types of things. So consequently, you could actually say both of those are true, and it's kind of where you come down, maybe politically, but also where you come down personally. And so, if you have great health insurance, you have great access. And if you don't, the access is limited in our country, and then the outcomes are not as good.
So we have lower levels of insured, higher levels of uninsured or uncovered population than comparative countries?
We do. We have in the neighborhood of 45 to maybe 50 million people that are uninsured. And those individuals, depending on what you look at, some of them are young people who feel bulletproof, and so consequently they just don't get insurance. But the fact of the matter is that about 80% of the people without health insurance in our country work full-time or are members of families where there's a full-time worker, and they just don't make enough to be able to afford insurance. So consequently, and that 45 to 50 million, which is probably closer to 50 now with our economy like it is, does not include those people who I would say are underinsured. Okay, meaning that they may have health insurance, but maybe they have a $5,000 deductible or something, so they have to pay all the way up to $5,000. So in essence, they have catastrophic coverage, but they don't really have insurance that covers them to go see a primary care physician or nurse.
And I suppose that one policy outcome of that is that individuals will defer or delay medical treatment in such a way that when they ultimately do access the healthcare system, their cost might be higher. Is that true?
Absolutely. Their default, if you will, someone with very high deductible health insurance or someone with no health insurance often is, again, a delay until they just can't. They have to get services, and then they'll go to an emergency room, which is far more expensive. And they may get referrals from there, but certainly those aren't covered either. And so not only is it a bad situation or a negative situation for the person and maybe the person's family, but it really, in fact, is a negative situation for all of us because there's a cost shift for those of us, let's say, that are fortunate enough to have insurance that covers primary care and that type of thing. Our rates are probably 25% to 30% higher to, in fact, capture the dollars that are lost when someone can't pay.
So we're paying one way or the other.
That's correct.
Okay.
We pay one way or the other.
One of the other outcomes of that economic situation is that with regards to personal bankruptcies, expenses related to healthcare needs are one of the drivers of personal bankruptcies in the U.S. And again, indicating that folks are really pushed up against the wall in terms of having the resources to cover necessary medical care.
And when they enter bankruptcy, then again we see that cost shift where those expenses are paid in some way, if not by the patient, then by the system.
That's correct. The system becomes, in essence, the default payer. And since we're part of the system, if we happen to be lucky enough to have health insurance, then we assume those costs aggregated across that spectrum.
As the hospitals and physicians try to cover the costs that are uncovered by insurance.
Absolutely.
And not paid by a patient.
Absolutely.
Okay. You've been listening to Spotlight on Policy, a production of Boise State University's Public Policy Center. My name is Stephanie Witt. Please join us for the next in our series on healthcare reform when we continue our discussion with Dean Jim Girvan about healthcare reform and our nation's healthcare system. Thanks for joining us.